Good afternoon, everyone, and welcome to the CDPH and CMA Virtual Grand Rounds. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's session, which is entitled Long COVID Update, What We Now Know. We all know that long COVID continues to present as a significant cause of chronic illness. Most of us have friends, family, and patients who have some concern about this, if not are suffering from deep distress. So I'm thrilled today to have Dr. Nisha Viswanathan here to present emerging evidence about the cause, outcomes, and the treatment of long COVID and tips for managing long COVID in outpatient settings. Next slide, please. We're going to show you in a minute our agenda for today. Let me get the slides to move forward. As we're doing this and waiting for the slides, I'll just remind us all that this series is accredited for CME credit. And just remember that you'll be sent a survey after the completion of the webinar where you can attest your attendance. Here are learning objectives today. After we get your completion, we'll send out your certificates. Next slide, please. While we're waiting for the slides, I'll just tell everyone that unfortunately Dr. Pan, who is our usual presenter, will not be here today. So we'll get started right away with our main speaker. So Dr. Viswanathan is an assistant professor of medicine and an extensivist physician at the UCLA David Gergen School of Medicine. Nisha attended University of Arkansas for Medical Sciences for medical school and completed her internal medicine residency at the Mount Sinai Hospital. She's currently the director of the UCLA Long COVID program and the subject matter expert on long COVID at AHRQ's National Long COVID Network. Nisha, thank you so much for doing this, what I imagine to be very hard work with the many patients who are suffering, and also for being here today to give us these updates.
Thank you so much for having me. As Kim just told us, I am in fact actually someone who has become really passionate about my work in long COVID, which started at the beginning of the pandemic when a lot of people who are just like you, a lot of physicians started noticing that patients after their COVID infection were having these persistent symptoms that weren't going away. And so my clinical practice at that time had a lot of openings, and so I started seeing patients for many of my colleagues. And with time, we started to realize that this was a ongoing phenomenon, that we were seeing it quite frequently, and that we really needed to work on having clinical solutions for our patients. So to that end, today I plan to talk to all of you about updates in long COVID. I know many of you know about long COVID. I think that the general medical community has understood that this is in fact an issue that we are dealing with. But really, I think we're still having a big issue with identifying who may have long COVID and what can we do to help manage their care. So next slide. I have no disclosures today. Next slide. So as our objectives today, primarily, like I said, determining who has long COVID based on the new consensus definition that came out in 2024, and then really understanding what is leading to our patients' symptomatology, and then also understanding treatments that are that we have found to be effective in both studies and in our clinical practice that can actually be things that you can implement from your clinics as well. Next slide. So as many of you may know, there was no consensus definition around long COVID until 2024. And this was in large part because it was and remains a diagnosis of exclusion, where we exclude other medical conditions. There still remains no FDA-approved testing criteria. And the RECOVER studies actually did show us that there were no standard blood tests that are being done that can actually help us conclusively identify long COVID. So having all that as our background, creating a consensus definition really did take time and took the effort of a lot of experts in this area to help kind of determine this in very broad definition that I think has been really helpful, though, and really for many of our patients pursuing that disability or that time off that they really need. And this is really the crux of it, is remembering that long COVID can happen to any person of any demographic background after any level of COVID infection. It may not always, the symptoms may not always present initially right after their infection, can wax and wane, and that it can also lead to exacerbations of their chronic illnesses as well. Remembering that these symptoms, even if patients look okay in front of you, can still be impairing their ability to live their lives, have social encounters, and work productively in our society. Next slide.
Nisa, it sounds like the slides are moving slowly, so we're working on getting that up front. But
well, I mean, I'll just say that in my clinical experience, having that definition, I know is very broad. And so there are many physicians who say, I have patients who definitively don't have long COVID and could potentially even fall inside of this definition. And so I think, we'll use today's talk to kind of help guide you in terms of who may be a person to think about. But, I think that realizing that a lot of our patients may actually be struggling with these things and not always necessarily bringing them up with us is a way of keeping long COVID in the back burner as a differential for potentially everybody. As of last year, I think there was a thought that at least 1 in 9 or 1 in 10 Americans is struggling with long COVID. And so that just really shows us that we are underdiagnosing it in our clinical practices. And in my experience, a lot of people feel a little uncomfortable, perhaps, making that diagnosis for their patients, especially if in their clinical practice they themselves have not seen many patients with long COVID. But I think it is just a matter of saying, hey, we've tried to look for a lot of things, but it really does sound like you may be experiencing long COVID. We'll rule out other possibilities, but I do want you to be aware that this could be a possibility. Many patients won't always even say these symptoms started after my COVID infection, or they may not have realized they had a COVID infection. Many patients are not testing nowadays. They are, they're not disclosing to their providers that they had COVID at all. And that can make it actually increasingly difficult for us to really make that diagnosis. So keeping that in mind, I think even in my own primary care practice, if I have patients coming in with some of these symptoms that we'll talk about, but brain fog, fatigue, shortness of breath, I do inquire in that timeline when I ask them about when it happened, have you had COVID in the last year, for example? I will say also that having had COVID rather remotely, so if patients say I had COVID in 2020 and symptoms started now, that wouldn't really, in 2025, I wouldn't necessarily tie the two events together. But this is not to say that they may not have been re-exposed or had another viral illness that they didn't attribute to COVID. So just keeping all of those things in mind.
we're still working on the slides, so I don't know sorry to put you on the spot, but keep talking.
Absolutely. I think that in that case, I'll kind of briefly talk to you guys about what are the most common symptoms I'm seeing and how I'm recognizing that a patient may have long COVID. So in our clinical practice now, I will say that COVID itself has really transformed. The original COVID, especially when patients were not really vaccinated or had a prior COVID infection, it was very different. The numbers really showed that probably 30 to 40% of people who were exposed to the original alpha variant of COVID had long COVID. Progressing forward in the timeline, Omicron does not have that level of frequency. It's like I talked about 1 in 9, 1 in 10. So we're probably talking about 7 to maximum 10% of the population being impacted. And this is an adult population. I know pediatric statistics are a little bit different. And the vaccination rates in pediatric populations are also slightly different. Scientists have in large part attributed the fact that long COVID is decreasing in part due to a few things, but can we go back one slide? are attributed in large part to the fact that both the virus is weakening and that, oh, I think we're moving forward, not backwards. Um, the virus is weakening and that I think we may have to move back one more slide. The vaccination rates have been higher. All right, perfect. So when we talk about risk factors about who may have long COVID, these are patients who, if patients are talking about certain symptoms, knowing what their clinical background is can also help you determine if they may be struggling from long COVID. So there was as part of this National Academy study, there were risk factors that were identified, having multiple chronic medical illnesses, being previously hospitalized, but also a slew of other medical conditions that can be tied to an increased risk of long COVID. But non-clinically speaking, there are also factors that we have noticed. In fact, women seem to be having long COVID at a rate of 2 to 1 compared to men. Being from a lower socioeconomic status or having even just other social determinants of health that may be impacting other of your health outcomes can impact your ability to get long COVID. And one of the other big things that was cited actually out of a British study was that inadequate rest after COVID could actually lead to long COVID. So using this is actually just something to keep in mind that for many of our patients, if they're not feeling well after their initial COVID infection, that we as primary care doctors can always have a role in providing them that time, that FMLA time, to allow for recovery and recuperation that could help them actually prevent disability down the road. Next slide. So who may have long COVID? So this is the big crux of the matter, right? And so I think the symptoms that we are seeing now that could have evolved from 2020, that could be new after their COVID infection this year, is that primarily I will say the top biggest symptoms are fatigue, brain fog, and then these symptoms of palpitations, dizziness, and so on. And patients don't tell you those symptoms in the way that I've just told you. A lot of times the things I hear are very similar. I'm so run down all the time. I suddenly feel really old. I just can't do anything and I will crash. My sleep seems to be really inconsistent, or when I wake up, I just feel like I haven't slept at all. I'm sleeping too much. It feels like I'm thinking through molasses. I'm having brain fog. I can't focus. As well as these, the palpitations. They'll say my heart is racing, or the way that they'll tell you is my anxiety feels really high. When I get up to walk around, I get really lightheaded, but a lot of times they'll also say, I'm dizzy. And then some patients will just say, I can't do anything. I have to lay in bed all day. So these are really, I would say, some key words to focus on. But that being said, remembering that long COVID can actually impact any part of the body. And so that patients will tell you things like they're having tinnitus and ringing in their ears. They're having new and worsening GI symptoms. Diarrhea and nausea are the two most common symptoms here. We now actually have a study showing that COVID seems to be an independent risk factor for developing long-term kidney disease. So definitely some degree of organ damage there as well. Muscle pains, joint pains, and then also the shortness of breath. I will say, though, in my clinical experience, the shortness of breath is less common than it was in the original variants of long COVID. And I'll talk to you about why this may be and how the more we're learning about the pathophysiology of long COVID, why this might be happening. Next slide. So now we have proposed mechanisms for what could be going on. If there's one thing that you should take away from this talk, it is that long COVID is probably an umbrella diagnosis. It's actually a terminology for at least 5 or 6 different pathophysiologies that may be occurring within a person's body that could be leading to symptoms. And this can in large part explain the fact that no 2 patients with long COVID look the same. And so today I'm just going to talk to you guys briefly about all the research that's really going on in this space, because I do think it will help inform our treatments when we down the road, and also helps us in terms of how do we think about our patients and what's going on with them. So I think, just taking here a look at the proposed mechanisms, if you look on the far left, there's this idea of immune dysregulation. And these are our patients that you may see coming in talking about, I've done testing for Epstein-Barr virus or herpes, human herpes virus 6. They're coming back positive. And then, or I'm getting sick all the time. And there's this idea that the immune system is actually getting dysregulated as a result of having had COVID. And it may either be reactivating old viruses or underlying other pathogens that could be laying dormant in our system. So we have seen, for example, after patients get COVID, there's an increased risk of them also having a shingles infection subsequently. And so, so this is one of the theories behind long COVID. Another is this idea of the microbiota dysbiosis. And this actually comes from the fact that we now know that COVID itself can present with this persistent viral reserve. And the only place that we've been able to consistently find that is the COVID virus can live actually in our GI tract for up to 6 months after the rest of the virus dissipates. This is in large part why we actually tell people, oh, you know, you should wear actually a mask when you go to the bathroom. It's because when you flush the toilet, the COVID can actually vaporize from there. And so these people can be cleared to return to work, their nasal swabs will come up negative, and yet they're actually still having active viral replication in their system, and they'll present with diarrhea for a very long period of time. This can obviously cause shifts in the microbiome that we have experienced, and for many of these patients, you may see increased diagnosis of, for example, small intestinal bacterial overgrowth. They may get diagnosis of functional dyspepsia. They may have and then, you know, there'll be quite the workup around these things. But really, it looks like COVID itself could be disordering the GI tract and causing this almost long COVID GI syndrome. Then there's this idea of autoimmunity that could be occurring as well. And effectively, what's happening here is that what we now know is that some of the ligands that are on the COVID virus itself mimic ones that are in our system. And so as a result of that, even if the COVID infection is gone, our body has now developed immunity to those ligands, and now when they recognize them in our own system, causes autoimmune response. And so we have seen, as a result of this, more patients who may be identified as having, for example, a seronegative spondyloarthropathy or these other autoimmune illnesses. It can be much harder for these patients to be able to get treatment if we're not able to identify what is actually occurring for them. But this autoimmunity seems to have also a strong basis in the literature. I'm going to skip number 4 because we'll talk about it a little bit more in another slide, but the 5th one here is this dysfunctional neurologic signaling. And this is basically this idea that when COVID comes into the system for certain people, it actually enters through your olfactory nerve, which obviously then impacts taste and smell. But then when its first entry point is actually into the brain. And the idea here is that at that point, it leads to disordered neurologic signaling coming from the frontal lobe of our brain, thereby impacting, you know, causing brain fog, changes in mood, and then also other sequelae related with that, including you can even have dysautonomia, which we'll talk about, small fiber neuropathy, where people feel like ants and are kind of all over their body, or they're burning and tingling, muscle aches, things of that nature. And so, you know, these are our prevailing theories of what could be happening around long COVID. Next slide. That being said, on the number 4 reason that we could be having long COVID is related to this increasing idea around the fact that it's the virus is creating an endothelial dysfunction. And this is actually causing long-term changes to the stiffness and size of our blood vessels and even their quantity. And so this is actually leading to decreased blood circulation, increased risk of blood clots, and that ultimately this could be part of the source of maybe a potential hypoperfusion of our tissue that really leads to patients having this ongoing fatigue. Next slide. There was a big study that actually came out in October of last year that is worth remarking on. And effectively in the study, they looked at a large number of people over a period of time of since the beginning of the pandemic, and ultimately determined that patients were people who had COVID could be actually deemed as having an independent risk factor for developing coronary artery disease. And that even if you looked at their thrombotic plaques, they would increase at a rate that was much higher after COVID than they had been previous, even if they were well stabilized. And there seemed to actually be a relationship with the ABO genetic type. So there was actually non-O type blood, so A, B, AB, all seem to have a higher risk of actually going on to develop blood clots actually as well. And so there was another big study that was also done out of the VA that did show that looking at, I think it was at least 100,000 people, that having had COVID increases your risk for having any type of blood clot for the next 3 years. And the only reason they were able to say 3 years is that was when the study timeline ended. That does not actually mean that that is when the risk decreases. And this I actually can say from my own clinical practice is something I'm seeing over and over again. Patients who may have had a little bit of mild CAD who are suddenly presenting with MIs or strokes. I definitely would say we have an increased number of people who are being diagnosed with DVTs and PEs. So just keeping this in mind, especially if your patient has had COVID here in the last year and they are older, they may already have some other risk factors, and this just can help push them in that direction. So especially when patients are coming to you with symptoms, always considering, maybe should I consider a D-dimer? I have diagnosed now multiple PEs in the process of patients talking to me as part of my long COVID program. Next slide. In the pulmonary system, we're realizing increasingly that long COVID itself is not actually a primary pulmonary issue. It seems to be almost related more to the vascular dysfunction and some of the other mechanisms, but it is worth noting that COVID itself can actually damage the epithelial lining of the airways, causing apoptosis, and then ultimately these patients can have decreased lung function as a result of that COVID infection. Next slide. And as part of that, getting a pulmonary function test can be very helpful. The brain fog is another substantial symptom that we see over and over again. And I think it is important to know that the brain fog is not always, which I've seen a lot, attributed to either a mental health issue or to a fact that they may not be able to concentrate necessarily. When they actually studied patients with long COVID, they found that when they did a lot of the tests, like simple reaction time, had them actually do other cognitive tests, they were able to see that there was a 2 to 3 standard deviation slowing in their cognition, meaning that it was independent of all the other issues that they had, could not account for the slowing. Next slide. This is a major issue that I think is worth talking about, is that if you do have such a substantive cognitive decline for people, what does that mean as a work implication? I will say there have been 2 studies now done on older patients, so patients who would fall in your 65 and older category, and they evaluated them after their COVID infection to see to what extent did we have this ongoing issue with cognition. And really, they found that if you had a more severe infection or had longer symptom duration after your COVID infection, there was a higher probability that you would go on to have a cognitive decline. Up to 2 years, they were seeing it after the infection. And once again, it's not because that risk stops at 2 years. It's because each of these studies has only been monitoring this for a certain amount of time. Similarly, they did another study that showed that basically for people who already had mild cognitive impairment, for example, when they were following patients after their COVID infections, they just saw that there was an increase in their white matter lesion burden, and that also they were seeing a decrease in their cognition as well. So something to keep in mind, especially for your older patients. I tend to tell my patients that long COVID is really a disease of aging on the body, especially when it comes to cognition. We're seeing really probably things that may have occurred to you a decade from now are now happening to you right now. And so this can be really tough also for your patients who may be, still in their late 60s, early 70s, to suddenly feel like in their late 70s or early 80s. And it is, I do think that there is a lot of adjustment associated with this. It can be really challenging, but I do think the thing that is really worth noting is that we as a society our health systems are really only prepared for what we assumed would be the issues of today, not the idea that we would be dealing with the number of these patients who may be having cognitive issues that we would have expected 10, 15 years from now. Next slide. In addition, there have been a few other studies that have shown that there may be some dopamine neurons have been affected in the process of having COVID. It seems like COVID, when it does enter through the brain, can cause neurons to lose the ability to grow and divide, and this can ultimately decrease dopamine release and lead to Parkinson's-like symptoms. I've also seen many patients now who have baseline diagnosis of Parkinson's, and as a result of having COVID, their Parkinson's disease has also accelerated or become unmanageable on their current treatments. Next slide. So further from this, there was a study done this year. It's in preprint, but I think it is notable to talk about, in that it's not necessarily going to change our clinical decision making, but something to support this idea of autoantibodies. And these autoantibodies specifically potentially targeting the neurologic system. It was a small study. They looked at samples of 55 individuals, and they basically tested them against 21,000 autoantibodies that they had. And they basically saw that based on what the human symptomatology was, the autoantibody associated with a portion of the brain that we would expect to be impacted was lighting up almost every time. So for example, patients who were presenting with vertigo or dizziness, and then they would check their autoantibodies, they would say that areas in the cerebellum were actually being impacted. And they were using their antibodies in mice models. So they were introducing the long CoVIn's convalescent serum into a mouse to perform this experiment. The tough part here is obviously we know it's in preprint. I know that they're still talking about potentially getting a larger sampler size so that there's something more to present here. But I think it really does show something that we may be dealing with, really this autoimmunity in the neurologic system, which is not something that we as healthcare providers have had to actually traditionally deal with. I think overwhelmingly we've always been able to search for our autoimmune illnesses in blood, and now considering we may need to also extend that to CSF is kind of a new and emerging area in long COVID. Next slide. I will say though, despite the fact that there's this talk of cognitive decline, for many of my younger patients, especially with that dysfunctional neurologic signaling, definitely uncontrolled depression and anxiety is something we are seeing over and over again. And especially in the areas of attention, processing speeds, short-term memory, which are just, and their ability to have word recall are disproportionately the areas that we we'll hear our patients talking about over and over again. And for those patients, they also tend to have an overlay with fatigue, and they may have other pro-inflammatory markers as well. We sometimes do see that elevation in ESR and CRP. Next slide. Also important to note that if your patients had previous depression and anxiety, especially if it was uncontrolled prior to their COVID infection, higher risk that it will become more uncontrolled as a result of having had the COVID infection. So we do consider one of the syndromes associated with long COVID this worsening mental health picture. Next slide. The other one worth talking about, which many people have probably heard either the patients talk about or has become more of a buzz topic, has been the words dysautonomia, or more likely POTS, postural orthostatic tachycardia syndrome. And I think really recognizing dysautonomia is kind of the best way of being able to address it. There's actually quite a lot in the literature about how to treat and manage dysautonomia. Dysautonomia is basically this idea related to this abnormal neurologic signaling that can cause a panoply of symptoms. So not only will the patient have these cardiac symptoms like chest pain or palpitation, but they can actually have fatigue, exercise intolerance, the same brain fog. They can have associated with it small fiber neuropathy, so the burning, tingling in their extremities. They can actually present with redness in their hands and feet. They can also have other symptoms, including pelvic issues and sexual dysfunction. They can have hot flashes and also a lot of sweating. So a lot of symptoms that are really associated with this. As part of that, the one that we see most frequently in long COVID is postural orthostatic tachycardia syndrome, or POTS. And this is basically when patients stand up, they'll tell you, I feel dizzy. And then when you go to check them in clinic, you'll see that they have an increase of their heart rate of 30 beats per minute, higher from their baseline of when they were laying down would be ideal. There is a study now that has come out in Nature in Cardiology, which is showing that POTS is probably as likely as up to 30% of patients who struggle with long COVID. So recognizing it is really important, because in reality, we actually already have a lot of knowledge in this space to manage and treat patients, which is, I think, even better than where we stand with a lot of the other issues that we are seeing in long COVID. Next slide. In your clinical practice, something to consider, there are assessments. So there's a written assessment called the COMPASS 31, which can help us establish dysautonomia. You can also do orthostatics, and very specifically the NASA lean test, which in that picture you can see there is a patient leaning up against the wall. And really it's a matter of checking their vitals at minutes 1, 3, 5, 7, and 10. And we really do have them lay up against the wall simply because dizziness is so common in this patient population. But if you don't see that jump in their heart rate, or if sometimes these patients with the dysautonomia may present with orthostatic intolerance as well, so a drop in their blood pressure, 20 systolic or 10 diastolic. Getting an autonomic reflex screen can be really helpful, or even a tilt table depending on your institution. But I will say, for those of us who are currently in Southern California, even getting these are proving to be a little tough. But just knowing that the autonomic reflex screen, if your institution does offer it, can actually also test for small fiber neuropathy. So it can be helpful in making that dual diagnosis for your patients who may be having the burning and tingling, and may also be experiencing the lightheadedness, the palpitations, and so on. Next slide. Another syndrome that has an overlap with long COVID is myalgic encephalitis, chronic fatigue syndrome. So by definition, before long COVID existed, this required a reduction, or basically an inability to perform at the level they were previously, activities due to fatigue that lasted greater than 6 months. But now with long COVID, we say that long COVID associated ME/CFS can really just be greater than 3 months. These patients will have what we call post-exertional malaise. They won't always describe it as such. It will be basically, I crash, or I am just exhausted after I do any type of exertion. And it doesn't need to be they ran a marathon. I mean, it literally could be I went to the grocery store and came home. Unrefreshing sleep is part of this. But as you can see, there is this overlap even with that POTS and dysautonomia area, because patients can have orthostatic intolerance or the cognitive impairment issues related with it as well. But in addition, if patients don't have that, there's a lot of common additional symptoms that patients will let you know. We call them kind of minor criteria. I won't go into it too deeply, but basically these patients will have issues with sore throat. They'll have the GI distress as well. They'll also have joint pains. They'll have a lot of temperature dysregulation issues. And immune system dysregulation as well. So there is a lot of talk of, I just get sick all the time. Next slide. Really, in the research that we found, the reason that we are kind of linking this myalgic encephalitis chronic fatigue syndrome to long COVID is really related to mitochondrial dysfunction. It's leading to probably a decreased exercise tolerance, leading to decreased oxygen extraction in the tissue, and ultimately probably leading maybe to decreased cerebral blood flow, decreased metabolic rate, or having just other neuroinflammatory issues as well. So, there hadn't been nearly as much research done in ME/CFS prior to long COVID, but now that we have long COVID, I will say this has become a robust area of research because there are just so many patients who are impacted. Next slide. So now really recognizing long COVID and understanding what causes it still leads us to the question of what are we going to do to take care of our patients? So next slide. So I think I'll kind of divide this into what are we using to treat long COVID, what are we using to prevent long COVID, and kind of here first is another preprint that actually discussed the role of potentially being able to use Paxlovid in long COVID prevention. And it was a study amongst veterans, and they actually evaluated them. And they weren't even, this was a retrospective analysis. So patients were either offered Paxlovid or weren't, and they had at least one cardiovascular risk factor, which extended to coronary artery disease, hypertension, hyperlipidemia, diabetes, or even having obesity issues. And these patients, at least 52% of them, I think, have received the Paxlovid, which is normotrelvir, ritonavir, and they found that overall, when they tracked these patients out for about 6 months, they found that there was about a 26% reduction in patients developing symptoms associated with long COVID. Interestingly as well, the study did comment on metformin, so I'll talk about that in the next slide. And really, when they did a different study that was actually published in Lancet in 2023, where they looked at metformin and its role in potentially preventing long COVID. And they found that for patients who were offered metformin at the time of their acute COVID infection for about 5 days, actually went on to develop long COVID at far lower rates than those patients who were not given metformin. So that being said, the dosage, I always get asked about this, 500 milligrams BID would be the dose that was on this one. So something to consider in both of these studies is potentially utilizing these medications to help our patients. In my clinical practice, honestly, I have been utilizing the normotrelvir, ritonavir a lot more, especially just knowing that the downsides could be minimal, even though there are a lot of drug-drug interactions, versus the upsides of avoiding long COVID could be big. So one of the other things to note is that that study really shows its benefit for normotrelvir, ritonavir during COVID. So far, there's been no trial that has shown that the utilization of normotrelvir, ritonavir after COVID or when patients are having long COVID is successful at treating long COVID. And so I think that kind of letting your patients know if we're going to do it, we have to do it now when you have COVID might be a persuasive way of helping them take the medication. I know a lot of patients have expressed, hesitations about the drugs, which I don't fault them. We are dealing with older HIV medications that have their own side effects, but the upsides could be large. Next slides. Role of vaccination. So this one has been one that I think there have been a lot of studies on. I'm citing here one from 2024 that was in the New England Journal of Medicine. There was another study that actually just came out now in 2025 that also did show a possible role for vaccination. But overall, they actually found that patients who were vaccinated based on the era that they had COVID really determined what was their rate of developing sequela of COVID-19. And basically, I think in my conclusions coming from this study is that the COVID vaccine seems to be actually a very effective way, depending on the study, a reduction rate of anywhere from 8% to 25% reduction rate of long COVID. So that could be also a huge way to convince the younger patients to consider getting vaccinated. The studies did focus on mRNA vaccines, so we do not have the data on non-mRNA vaccines. Specifically, I think I'm referring to the brand name Novavax that's now newer on the market. But that being said, for many of my patients who had really rough encounters with the mRNA vaccines, sending them in the direction of a traditional protein-based vaccine could still have a lot of upside potential of preventing long COVID subsequently. And so I think sometimes having this, the more knowledge we have to present to patients, the more likely we can get them to increase their rates of vaccination. I think overall we've seen that really the highest rates of vaccination are on those where patients really have those conversations with their providers who are encouraging them to get vaccinated. I do think I should also just bring up, I think many people have seen that there was a recent study that I think came out of NYU regarding vaccination and could there be a post-vaccine syndrome. And if you look at the study itself, the sample size was very small, and their relationship of if there could be a relationship between the COVID vaccine and subsequent sequela, effectively, the writers of the study themselves acknowledge that this should be an area of further research, and that it should encourage us to to also focus on making even safer vaccines. But I think at this point, one of the questions I always say is, when patients decline to take a vaccine, do they also understand what they could be giving up? And that's really, I think, where this is it's a risk-benefit conversation. One of the other conversations around vaccination that I've heard is the concern of myocarditis. Now the CDC has advised that for younger male patients to space the 2 doses of COVID vaccination to help limit the risk of myocarditis. But also when patients bring that point up with you, remembering that the COVID virus itself causes myocarditis at a rate of 19 times the level that the COVID vaccine does. So once again, understanding that what you may be giving up in protection may actually result in something potentially worse occurring to the body. So next slide. Now, this is another medication that we are seeing now in the treatment of long COVID that does seem to have quite a lot of potential. Low-dose naltrexone is a medication that is a compounded version of naltrexone, the medication we use for opiate use disorder and alcohol use disorder, to actually treat this chronic fatigue. It already had a place kind of in the world of ME/CFS, but now we are seeing it increasingly used in long COVID. In the study done in 2024 last year, it was a small study of 108 patients. They did see a statistically significant decrease in fatigue and pain. Usually in our clinics, we start with a dose of 1.5 milligrams and slowly increase at a rate of 1.5 milligrams until we reach a dose of 4.5, or sometimes I'll go up to 6 milligrams for my patients who have obesity. The biggest issue is that side effects can be related to the GI. They can have some itching, but the itching tends to resolve. And the most important thing is if your patient decides to pursue this treatment option, that you should let them know we need to commit to at least 6 months. The study showed that having a length of time on the medication is what led to symptom resolution. Next slide. Another study showing a promising modality was hyperbaric oxygen. It's another small study. Unfortunately, in the world of long COVID, there's a lot of small studies. 31 patients. It looked at doing daily sessions for about 40 days, and they looked at using this 100% oxygen protocol. Ultimately, I actually have, in my clinical experience, had multiple patients who decided to pursue this. It's not something that's covered by insurance either, but for those patients who are interested in trying this, I have seen a lot of people have symptom improvement. There is a caveat here. For many of them, I will say, after they discontinue the hyperbaric oxygen therapy, within a couple of months, they say that much of their fatigue and brain fog does return. So it may not be a tenable long-term solution unless we do get that insurance coverage around it. Next slide. Additionally, there was a study last year looking at the role of potentially using nicotine patches in long COVID. Our clinic, all of our physicians, we sat down and did a journal club on this article. Our conclusion was we are not recommending nicotine patches, but there does seem to be an impairment of the acetylcholine neuromodulation system, and this could be why other neuromodulators are proving effective. Next slide. So to that end, other neuromodulators here we're referring to are actually SSRIs, SNRIs. We're having a lot of success in actually utilizing our medications that we use, off-label for ADHD. Bupropion, vortioxetine, atomoxetine have been really successful. Your classic stimulants of Adderall and Ritalin, I'll say it's a little bit more mixed picture here. It may help with the brain fog, but it may leave them worse off in terms of their fatigue. There was another study looking at the role of guanfacine, which we'll talk about here in a second. Modafinil, which is, off-label, is labeled for narcolepsy, but off-label also for idiopathic hypersomnia. So if your patients seem to be struggling with that, modafinil has been really helpful. And then memantine has actually also been really helpful for managing our patients with both brain fog and headaches as well. So to that end, I think that, the way we do that in the protocol that neurologists follow are 5 milligrams daily for 1 week, 5 milligrams twice daily for a week, 10 milligrams in the morning, 5 milligrams in the evening for a week, and then 10 milligrams BID going forward from there. A lot of success with that one. Next slide. So the guanfacine, this is actually a very interesting study. They actually did a combination of both guanfacine, which is a really old blood pressure medication that seemed to also have impacts on cognition, with a supplement called N-acetylcysteine, which was given at a dose of 600 milligrams BID. So the guanfacine is prescription, the N-acetylcysteine is not. But basically in this study, they followed these patients for about 6 weeks, and they found that effectively they did have improvements in their brain fog, cognition, and were actually able to resume certain amounts of normal work. Guanfacine also can play a real role in POTS sometimes too. I haven't launched into a huge discussion of treatment of POTS, because truthfully that's almost a talk in and of itself, but it is something that it can be utilized in both areas. Guanfacine, very interestingly, it just increases, it looks like COVID itself can increase a couple of neurotransmitters called kynurenine and some of our calcium signaling, and both the guanfacine and the N-acetylcysteine can really play roles here in kind of blocking that upregulation of that pathway. So I always tell patients you need to take both. Guanfacine by itself sometimes works for patients, but I find that for many they need to take both if they're going to have success in this area. Next slide. Vagal nerve stimulation is one more potential therapy. They did a study here in 24 actually looking at utilizing vagal nerve stimulators, and they did see that there was an improvement in cognition, mental health disorders. The biggest thing about vagal nerve stimulation is, once again, getting it covered by insurance. It is a modality that is covered for refractory migraines. So that has been, the population have been successful in getting coverage. But I think the tough part about it is they put electrodes on, and they have to get enough electrical stimulation to make the side of their mouth twitch. And that has been an area that some of my patients have found they have not always been necessarily comfortable with. So it is something you can discuss with your patients. It does show some promise, but may be difficult as well. Next slide. The treatments of POTS and dysautonomia, I'm just going to review this very quickly. The crux of this is if you do identify patients who have the dysautonomia, considering some basic strategies, including increasing their salt intake up to 4 grams a day, fluid increase to about 8 liters a day. You can consider the use of midodrine, fludrocortisone, beta blockers, but you might want to involve a cardiologist in this. Considering using the Levine protocol, which was something that was created actually at the Children's Hospital of Pennsylvania, to basically start with progressively from recumbent to standing, slowly a 12-week protocol to get patients to be able to stand up more and more on their own. You can actually find it online in a PDF format. I usually just print it out and give it to a physical therapist, and they work with the patients in this area. Next slide. The cardiac symptoms of long COVID, one last thing to mention here, the American College of Cardiology does recommend doing additional cardiac testing anytime patients are presenting with fatigue, chest pain, shortness of breath. And so out of that, usually we always say standard in the primary care realm, EKG, troponins, and echocardiogram. If there's ever anything abnormal, considering a cardiac MRI. If it's normal, you can always consider involving a cardiologist further. But if everything comes back normal, considering at that point that they probably have a long COVID source of their symptoms. Next slide. So where are we going with long COVID? I gotta say it's definitely a public health emergency, and there probably aren't enough resources dedicated to it at the moment. Next slide. Really at this point, while the rates of long COVID have decreased, as I mentioned, going from, 30% down to 7 to 10%, we do know that it is having a huge impact on lost wages, and that could have an implication in our society long term. Next. And then, really here in California, we're probably dealing with at least 2 million individuals who are struggling with this illness. Next. And, as part of that lost GDP, we have a lot of people who are leaving the labor force as well. Next. This is really just kind of summing up my talk is that, a lot of these patients, they have real disability, and that we as their healthcare providers really need to work on them on what options we can do to create a sustainable life around them. So as part of that, not only do, we give people a lot of short and long-term disability, we do consider out alternative ways for them to continue to remain employed. And I've realized this is really important for people to continue to see worth in the life that they lead, especially young patients. I've seen people who are in their 20s who are just struggling. And I think having a place to go, work, feeling like you're part of society and doing something meaningful is very important. So to that end, here are some suggestions that we have on things that we do to help patients with balancing that ability to work and live with more quality of life. Next slide. If you do have a patient with long COVID and want to know more, the UC Health System did create a 6-hour CME course on long COVID. You literally can also Google UC Health long COVID CME. It is 6 online modules that you can do, and we'll provide more information in this area. Next slide. So really, I think if, the few things to really take away from this talk. Identifying patients with long COVID is really, I think, the biggest and hardest part. There are a lot of long COVID programs around the state. Almost all the UC health systems have them, plus additional programs are noted at many of the health systems. And so I think it is a matter of identifying patients to get them linked with care. But knowing that also there are some considerable wait times for patients, so considering also managing with some of the strategies we talked about today, talking to patients about things that are not FDA approved but could help them. And for many of our patients, especially talking about that group of neuromodulatory medications, your SSRIs and other stimulants, things of that nature, if indicated, considering to try these could help them with their symptoms rather than having to wait a long period of time to get seen. But I want to, next slide. I want to thank you guys all so much for allowing me to speak with you today. And I guess I'm going to be open for questions.
Thank you so much, Nisha. We did one of these, it's 18 months or 2 years ago, and we've learned so much, which is very exciting, and still seems like we have a long way to go, but just super grateful for this really comprehensive summary. As a pediatrician, one thing I just want to lean in on for a minute is, what does the epidemiology look like in kids and adolescents? Are you finding that it's a different syndrome in kids and adolescents? How does that present?
Yeah, so I primarily take care of adults, but I do have pediatric colleagues, and I have had this conversation with them. And there was a really good paper that came out showing that long COVID in children does not look like the long COVID in adults. And this is in large part because, especially when you're talking about younger children, but even kids who are adolescents, they don't understand everything that's going on in their body. And there's a lot of changes that are happening developmentally for them at the same time as long COVID symptoms. So the way that will actually look for pediatric symptoms is, they'll just say, I have to put my head down a lot. this test was too hard. It's, you know, they express it in a very different way, or they'll say, you know, everything's really fuzzy. Like I can't think right now. I'm like, and a lot of patients will also say, I just can't do sports the way I used to. Like PE leaves me exhausted.
Mhm.
So these are some of the triggers there in pediatrics to kind of think about, could this be long COVID that's going on?
Yeah, that's helpful. Um, One question was, do you have a standard kind of panel of lab tests that you do in anyone that you're suspecting long COVID? When do you go deeper looking for long COVID?
Yeah, absolutely. So, you know, just like those things we talked about, you know, having those trigger words, I think, you know, always, because this is a diagnosis of exclusion, think about the things that you would always think about, right? You know, if we're thinking about fatigue, could we be dealing with anemia? Could we be dealing with thyroid issues? Could we be dealing with vitamin deficiency, iron deficiency? I can't tell you how many people in this country are actually also just truly malnourished, and you just don't realize it until you start to do a lot of this lab work for them. In addition, I will say, in addition to your, you know, your standard CMP, CBC, vitamin, TSH, we do also recommend checking for other viruses. So if you're dealing with brain fog, looking for syphilis, hepatitis C, HIV, we do, as we've discussed about the reactivation of viruses too, we do standardly check EBV because if we do see that positive involving an infectious disease, doctor can be helpful. There has been one thing I didn't talk about, which is so new that I didn't want to bring it up yet, was potentially a role for acyclovir or even valcyclovir, especially if you see these patients with these recurrent herpes infections, not as common as we would normally put them on suppressive treatment, but they also have long COVID. There do seem to be a little bit of success in managing them with some kind of something suppressive there, because human herpes virus can have that link with long COVID. In addition, you know, obviously based on your patient's history, a urine drug screen could be indicated. If your patients are taking a lot of supplements, I would just recommend and check a urine drug screen. I've had multiple people's supplements be adulterated with things that we did not anticipate, things that were stimulants, things that were depressants, things that had marijuana in them. And this was, you know, like an 80-year-old grandmother taking, you know, some Chinese herb, and it turned out actually potentially sedating her. For a lot of these patients, are also the supplement thing is really big. You know, I always say coming off and slowly restarting might be the best way to really be involved in that regard, because there could be a role for supplements. I didn't even go into that here, but you know, you have to be careful, really. You know, there was a study that came out, ashwagandha can cause a lot of liver problems. And so, you know, this is merely to say that kind of needing to be more comprehensive. In addition, I would say, you know, if we're talking about brain fog, we haven't always found that MRIs are helpful, but if you have patients with headaches too, MRI with and without contrast is a good one. Echoes, Holter or Zeo patch can be helpful if you're dealing with palpitations and shortness of breath. Pulmonary function tests can be helpful in that regard as well. Sometimes just having your patients walk around the clinic and seeing if they become hypoxic is another way of identifying things. So there are ways to do this in a more rough manner, but so those are kind of our standard kind of go-tos.
Great, really helpful. Well, I wish I had all day, but I'm going to ask one more question. What is there's sex differences in how many people get diagnosed with long COVID? And one of our listeners was asking if maybe there's evidence for either testing and or treatment with testosterone in this condition. Do you have any?
That's a good one. So I will say this, testosterone, not as much, but there is an indication that for especially women, their menstrual cycles may be playing a significant role here in long COVID and their symptomatology, especially because for many of my patients come to either the time of ovulation or the time of their period, they will have a worsening of their symptoms. You know, there's also been a study that showed that COVID infection itself can change the menstrual cycle, and it can actually lead to early onset menopause. So I have had the struggle for many of my patients similarly in that regard.
Interesting. Well, clearly there's lots more to study and learn, but we really appreciate all of this incredible work, and thank you for all of that. Just reminding everyone, we are moving to a bi-monthly format this year, so don't forget about us. Our next session will be in May, We will then be able to review our winter respiratory virus and anticipate the summer, look at avian flu, and we'll also hear from the most influential organization you've never heard of in California healthcare, which is, some might say, the California Department of Healthcare Access and Improvement, otherwise known as HCI, about how we can improve primary care in California. So really looking forward to seeing you all there, and thank you for coming, and thank you very, very much, Nisha, for coming and presenting today.
Absolutely.